Hello guys, please like and subscribe my channel. Let's start with today's topic, that is molar pregnancy. This definition is according to DC Datta. It is the abnormal pregnancy with trophoblastic proliferation and hydropic degeneration of chorionic villi. When trophoblastic proliferation doesn't give any space for inner cell mass to grow, it means no fetal tissue, and it forms the complete mole. And when it gives some space to inner cell mass to grow, there are some fetal tissue known as the partial mole. So now you understand, complete mole is equals to no fetal parts and partial mole is equals to some fetal parts present. In complete mole, all villi are edematous. Karyotype is 46XX. Ovum without nucleus fertilized by one sperm and very high beta HCG. But in partial mole, there are some normal villi. Karyotype is 69XXX and 69XXY triploid, and normal ovum fertilized by two sperms. Now comes to clinical features. So you have to hardly learn the difference between them. One more difference is, in case of partial mole, maternal genetic material is present, and in case of complete mole, maternal genetic material is absent. Now, in case of partial mole, bleeding present in first trimester. In case of complete mole, bleeding present in first trimester, and history of passage of grape-like structures. In case of examination, in case of partial mole, the height of uterus is less than period of gestation, but in case of complete mole, the height of uterus more than period of gestation. Now, clinical features. When there is abnormal proliferation of the trophoblast, then there is abnormal pregnancy that has to be end. So most common is vaginal bleeding in first trimester, and there are grape-like vesicles are present. Then size of uterus more than period of gestation, and on per abdomen examination, it feels like Duffy abdomen. Patient will have PIH at early stage because trophoblast not able to overcome the resistance. On USG, there will be snowstorm appearance, and there is increase in the beta HCG, so it causes hyperemesis gravidarum. It can also cause hyperthyroidism because alpha subunit of HCG is similar to alpha subunit of TSH, and it can also cause bilateral theca luteal cyst in the ovary. These three can occur because of increased beta HCG. Now comes to investigation. As we studied, there will be elevated beta HCG. On ultrasound, snowstorm appearance is seen. In case of complete mole, there will be no fetus, and in case of chest X-ray, there is baseline for metastasis. Now comes to management. Primary treatment for this is suction and evacuation, and after evacuation we infuse the oxytocin for more contractions, and in case of Rh negative pregnancy we give anti-D. Follow-up is the most important key. We follow beta HCG weekly till it comes negative 3 times, then monthly up to 6 months. Combined oral pill contraceptive are used, and avoid pregnancy for 6 to 12 months. If we suspect gestational trophoblastic disease, then there will be rise of the beta HCG, and beta HCG positive even after 6 months. Now comes to and there are chances of metastasis. There are different type of metastasis, in which the one of them and most common is choriocarcinoma. So we will study about it. The most common metastasis is invasive mole, and the second most common is choriocarcinoma. The choriocarcinoma most commonly asked in NEET PG, so its definition is important. According to DC Datta, there will be a trophoblastic neoplasm composed of cytotrophoblast and syncytiotrophoblastic without chorionic villi. This line is very important. Characterized by early hematogenous metastasis and very high beta HCG levels. Comes to its etiology, it is an antecedent pregnancy. Complete hyatidiform mole is most common. It means there will be no fetal tissue. It can be occurred after abortion, after ectopic pregnancy, and normal term pregnancy also. There will be no chorionic villi, we have studied. Sheet of cytotrophoblast and syncytiotrophoblastic. Extensive hemorrhage and necrosis we have studied. It invades the myometrium and blood vessels. This comes under its pathology. Now comes to clinical feature we have studied. It's a part of molar pregnancy, so the features are similar. Persistent and irregular vaginal bleeding after pregnancy. Uterus subinvoluted. Symptom of metastasis. In lungs, the metastasis is most common and occurred symptoms as cough and hemosis. In brain, it causes headache and seizures. In liver, it causes the jaundice and pain, and features of hypothyroidism also present. Investigations. Beta HCG is markedly elevated. On chest X-ray, cannonball metastasis is present. We will show it in the picture. In USG pelvis, there will be an invasive mass seen. CT and MRI we check for metastasis. The most common site is lung, and other can be vagina, brain, and liver and kidney. Diagnosis mostly made on the basis of clinical feature, that is persistently elevated beta HCG. The most important key point is, I mentioned also in the last, that biopsy is contraindicated. How we manage this? Chemotherapy is the best choice for this. It is an extremely chemosensitive tumor. In case of low risk, single agent is used, that is methotrexate plus folinic acid, and in case of high risk GTN, Imaco regime is used. Imaco stands for E for etoposide, M for methotrexate, A for actinomycin D, C for cyclophosphamide, and O for oncovin. that is O. vincristine. It has excellent prognosis and 90% cure rate. Now the key points. In choriocarcinoma, there is no chorionic villi, most common after complete mole. Lung is the commonest metastasis. Highly chemosensitive, biopsy is contraindicated. These are the high yield and most commonly asked points in the exam. Now comes to FIGO staging. Stage 1, it confined to uterus. Stage 2, it extend outside the uterus but limited to adnexa, vagina and broad ligament. Now stage 3, that is most commonly asked, GTN with lung metastasis. And stage 4, metastasis to other sites such as brain, liver, kidney and GI tract. Now we study the choriocarcinoma versus the invasive mole difference, because invasive mole is the most common metastasis and choriocarcinoma is second most common. Invasive mole is locally present, but the choriocarcinoma is highly malignant. Invasive mole almost always after the common mole, but choriocarcinoma, it most commonly occurred after complete mole, but it can also occur after abortion and term pregnancy also. In case of invasive mole, chorionic villi present, and we studied in case of choriocarcinoma it is absent. When we check its histology, the hydropic villi invading the myometrium present in case of invasive mole, but a sheet of trophoblast like syncytial trophoblast and cytotrophoblast are present in case of choriocarcinoma. Beta HCG elevated in both cases. Mode of spread, it is local myometrial invasion and early hematogenous spread in case of choriocarcinoma. Metastasis in case of invasive mole is rare, but in case of choriocarcinoma is common. Now common mets, in case of choriocarcinoma this is lung, but in case of invasive mole it's rare. Then brain metastasis, brain, vaginal, both metastases are common in choriocarcinoma. Uterine size enlarged because it is locally invasive, so enlarged in case of invasive mole, and subinvoluted uterus in case of choriocarcinoma. Hemorrhage risk moderate in case of invasive mole and very high in case of choriocarcinoma. Biopsy is contraindicated in both of them. Treatment is chemotherapy, and chemo regime we have studied, that is single agent methotrexate, and low risk is single agent. In case of high risk it is imaco regime. Now comes to exam related question. Cannonball lung metastasis occurred in choriocarcinoma. Villi present in case of invasive mole but absent in case of choriocarcinoma. No villi plus hemorrhage in case of choriocarcinoma. Brain and liver metastasis occur in FIGO staging 4. You have to learn it by heart. Biopsy is contraindicated in GTN. Now we see some X-ray of GTN. Now we studied some images by doing MCQs. So first MCQ is chest X-ray shown below suggest which diagnosis. In the X-ray it is shown the cannonball metastasis in the lungs. It is stage 3. So the answer is choriocarcinoma. The second answer is metastatic invasive mole, but it is not, because it is not locally invasive. It is locally invasive. It doesn't spread to lungs. Then our next question is ultrasound image shows a bulky uterus with myometrial invasion. and retained molar tissue, most likely diagnosis. So there is bulky uterus, myometrial invasion and retained molar tissue. Then there is invasive mole because it is shown the local invasion, and we studied in case of choriocarcinoma there is subinvoluted uterus. Then third answer is gross specimen shown hemorrhaging and necrotic tumor mass with no identifiable villi. Then diagnosis choriocarcinoma because we have studied already there is no villi in the choriocarcinoma, and choriocarcinoma is hemorrhaging and necrotic tumor. Then our next question is histology image shows hydropic chorionic villi invading the myometrium. What is the diagnosis? We have studied it in case of invasive mole in histology that hydropic chorionic villi invade the myometrium. So the answer is invasive mole. Then next, MRI brain image in a patient with GTN so hemorrhagic metastasis. What is FIGO stages? Then it is a stage 4 because we have studied the third stage is cannonball metastasis in the lung, but the stage 4 is other site of metastasis, brain, liver and kidney. So there is brain metastasis, then answer is stage 4. So the topic of molar pregnancy ends here. I hope you are studying well because there are 4 months left almost for INI set, and date is not yet come for NEET PG. So study well and please like and subscribe my channel for more further videos. Thank you. Sorry to mention, in our next video we studied about the abortion and its type and its management. So be ready for it.